would, as we often do, open by asking if you have a cell phone, please silence it so it does not interrupt us in the midst of the meeting. And with that, I would ask that staff please call the roll.
Senator Douglas.
Here.
Senator Storm. Senator Webb. Representative Hart.
Here.
Representative Meredith.
Yes, ma'am. Yes, sir.
Representative Wilner.
Here.
Co-Chair Fleming. Present. And Co-Chair Givens.
Present. Next item of business is approval of September minutes. Chair will entertain a motion for approval of the minutes. Second.
Second.
All in favor say aye.
Aye.
Any opposed? The ayes have it. Record will reflect that the September minutes have been approved. Co-Chair, would you have any opening remarks you wish to make?
Thank you, Vanessa.
Members, please be advised we're moving rapidly toward conclusion. These sort of task forces are time limited, and we will rapidly be moving toward that November meeting when we wish to adopt some recommendations. So be on the lookout for thoughts. I know our staff has already put together some synopsis of recommendations built around the charge that we have in statute that created us for this temporary time period. So please, when you get an email from staff over the course of the next few weeks with a preview and a draft of what recommendations might start to look like, I would ask that you open that email. Don't be like me and leave it in the pile of emails that go unopened. Open that email, spend some time with it, be prepared to come back and be expeditious and productive at the next meeting. I also want to alert members there are 3 documents in your committee packet related to the Cabinet's response to questions from that September meeting. Appreciate the Cabinet providing those responses. Those are built around questions that we had in the course of the meeting and responses to those questions. So please review those, including one that we had asked and felt like this would be the case. The last time that reimbursement rates were changed in regulation was in 2008. What my notes indicate here. There was also a conversation about if treatment in place could be a Medicaid covered service, and ask about the Cabinet's willingness to come back next month and discuss that. And I think that's where we're going to open up today, if I'm not mistaken. So Commissioner Lee, if you'll come to the table, we would start there. As always, please introduce yourself for the record, and thanks for your willingness to help us move forward on this issue.
Good afternoon. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services. I appreciate being invited back to be able to discuss this very important project.
Just a little bit closer, thank you. And staff is encouraging me to let you know that the arrows on the keyboard will move the slides for you.
Okay.
I'm not certain if that's unusual or not.
We'll give it a try.
Okay, great.
But thank you for inviting me back to discuss this very important information, an issue that impacts Medicaid members. I want to start with a little bit of level setting with the Medicaid program. Just at a glance, what Medicaid is, what we do. Of course, we are a joint program. We're federally funded and state funded. In general, federal funds provide about 70% of the funding for the Medicaid program. We currently cover approximately 1.6 million members. We always say that's nothing to boast about because that means 1.6 million individuals in the state of Kentucky live at or below the federal poverty level. And so while we cover 1.6 million members, this issue related to emergency medical services will impact those 1.6 million, but there's another 2.8 million individuals in Kentucky who are also impacted by this issue. We do cover over half of Kentucky's children in our Medicaid or CHIP program. We have approximately 625,000 individuals covered in our expansion program and 1 million individuals in our traditional Medicaid program. We have over 60,000 enrolled providers. We do have 6 managed care organizations that provide services to approximately 90% of our population. In state fiscal year 2022, we had a $14.8 billion budget, and we had $78.5 million in capitation payments for non-emergency transportation. And I know this is about emergency medical transportation, but I think as we have this conversation, we need to see how we can better collaborate with our emergency medical providers and our non-emergency transportation based on some of the conversation that I heard at the last task force meeting. This is just a map showing you where our Medicaid members are. The counties colored in orange is the highest concentration of Medicaid members. And you can see that as we move from the east to the west, the concentration of Medicaid members drops slightly. Those blue counties are 21 to 40% of those counties have Medicaid members. Medicaid coverage for ambulance services, we went over a little bit about this at the last task force meeting, but thought it might be good for just a refresher. We do cover ground or air transportation at both the advanced and basic life support. Our emergency services, currently ambulance services are covered to and from a hospital emergency room in the medical service area. Providers do have to keep documentation for post-payment review, and transportation to another medical facility other than a hospital will be covered with certain documentation. We do have non-emergency transportation for individuals within their medical service area and also outside of their medical service area in certain conditions. So I wanted to talk a little bit about our non-emergency medical transportation program. We do have a non-emergency, we call it an EMT, that we provide under a 1915B waiver. This waiver allows us to waive, when we talk about waivers, we waive a certain provision of the federal rules. So in our 1915B waiver, we waive the provider, the choice of provider, freedom of choice for our members. We actually have outlined who they have to utilize. So the Department for Medicaid Services contracts with the Office of Transportation Delivery in the Transportation Cabinet. The Office of Transportation Delivery will contract with regional brokers that they select through a request for proposal process. The brokers are paid then a per member per month capitation fee, and then they contract with providers to deliver transportation either via taxi, van, bus, or public transport. It does exclude ambulance stretcher services. Members call the brokers and the brokers have to provide transportation within 72 hours. And they also have to provide urgent care. And I think this was important because at the last task force, there was a conversation about individuals who are transported to a hospital, and then maybe they need to be transported to a behavioral health facility or behavioral health hospital, and they would go voluntarily. In this case, it would appear that that's no longer an emergency transportation service, and somehow we could allow that non-emergency medical transportation service to step in and provide that transportation. So again, just trying to look for how those two transportation, the emergency and the non-emergency, can collaborate to make sure that transportation services are delivered in the right setting at the right time. Senator Givens, you did ask about the rates for the ambulance service the last time they were increased. The fee schedule has not been increased since 2008. However, the provider tax funding passed in the 2020 session, House Bill 8, did allow for additional funds to be delivered to those transportation providers, and it's funded through 5.5% tax by those providers. And again, just in 2021, we paid out over $45 million through that House Bill 8 legislation, and again in 2022 through August, we've paid out almost $30 million to those providers. So the main question was, how can the department, or what can we do to cover treatment when we don't transport? So I did go out and do some research, and back in August 2019, CMS issued an informational bulletin related to emergency triage and transport for Medicare. They proposed a 5-year payment model to provide flexibility following a 911 call by Medicaid or Medicare fee-for-service members. And they would provide transportation to alternative destinations such as a primary care office. However, September 13th, 2021, CMS withdrew their plans and did not implement that emergency triage and transport model. So Medicare Part B only covers to the nearest appropriate medical facility, which is a hospital, critical access hospital, or skilled nursing facility. And so Medicaid coverage of treatment without transport, we did a little bit of research. We reached out to some of our colleagues in other states. We found out that Indiana does cover treatment without transport through their state plan amendment, through their Medicaid state plan amendment. Massachusetts is also exploring, but they have not submitted a SPA or a waiver. Oregon is covering treat in place, but it's through a temporary state plan amendment, and it's only during the COVID public health emergency period. Tennessee plans on implementing in 2023, but since 100% of their members are enrolled in a managed care organization, they do not have plans for a SPA or a waiver. And Minnesota only covers it if the ambulance transportation staff provided medically necessary treatment to the member at the pickup point. West Virginia does allow codes to be billed for treat but no transport with a modifier. If they do a modifier, it is for the administration of naloxone through an 1115 waiver, and it is specific to substance use disorders. And so here I'd just like to explain the difference between a state plan amendment and an 1115 waiver. So a state plan amendment, or SPA, is an agreement between the state and CMS describing how we will administer the Medicaid program. The SPA has to have, it has to be statewide. It means we have to cover the same service across the state. We cannot charge or change services for one group of Medicaid enrollees. So, for example, the waiver that the other state had was specific to SUD, specific to individuals with substance use disorder treatment, and they could limit that group of individuals because it was an 1115 waiver. We also cannot waive the choice of providers. We are in any willing provider state. All providers that can deliver that service would be allowed to deliver the service. We could not carve that out. An 1115 research and demonstration project, it requests to bypass certain federal Medicaid requirements. So, for example, the substance use disorder is a really good example. If we wanted to create some sort of a waiver specific to the substance use disorder, we would carve that population out, or any population that we wanted to. It has to be budget neutral. It can't cost the state any more to operate that 1115 waiver than it would without that waiver. And there is a 5-year limitation with renewal periods and various reporting components to CMS. So what would a waiver look like? I think that's the question, Senator Givens, that you asked. We would have to define what we would want to waive. For example, would we want to do some pilot programs in specific geographic areas? Would we want to do something in an urban area versus a rural area, or one in each? We would have to define the specific providers. For example, in our 1915B waiver, we waive that freedom of choice, and the members have to go to the providers who participate in that waiver. We would also have to define the population, such as the SUD in West Virginia, for example. And we would also have to develop budget neutrality and reporting requirements. So going on to the next steps, if we're directed to cover treat without transport, we should enter into conversations with CMS. We would create a SPA or a waiver, and as noted in Indiana, treatment without transport could be accomplished through a state plan amendment, which is a little bit simpler than an 1115 waiver. If we wanted to explore the triage and transport, we would most likely have to explore an 1115 waiver, because we would ask to waive the location to which those emergency providers could transport an individual. So, for example, if we wanted to allow the triage, and transport to an urgent care center or a physician's office, that would require a waiver, because that service being provided by an emergency transportation provider is no longer an emergency when it is transported to a physician's office or an urgent care. So that's where the waiver would come in. We would also have to amend transportation regulations. Based on Indiana's experience thus far, we would anticipate the need for additional funding. We have guessed at approximately $5 million, or we've anticipated $5 million based on Indiana's experience. Of course, Kentucky's experience is going to be completely different than Indiana's, but that's the information that we had to go on. We would have to specify a time frame for when we would want to implement. And of course, we would ask that we continue to collaborate with this task force so that we could create the best program possible. And with that, I'd be happy to take any questions.
Well done. Truly. Thank you for your commitment to this conversation. Thank you for your willingness to engage in it. In your next to the last slide, next steps, you started with the statement, if directed to cover. Your statement, if directed to cover, indicates you would prefer the legislative body in coordination with you, provide you direction to cover these services, or are there other, or we must provide you that direction, I presume. You tell me.
I think that we can continue to explore all of these all of the logistics of it. I again would like to stay in conversation with this committee. Sometimes legislation, if we draft specific legislation, sometimes it ties our hands and we can't be as flexible. But we do want to maintain flexibility and would definitely continue to work with this committee as we move forward to formulate a plan.
I sense this committee and the provider community would like the chance to work with you as well. I'm confident, too, that dates drive us to get things done. And so in that conversation, we would want to know that there's a date certain by which we can arrive at an answer. And I think that's fair to ask. So
And I think I can definitely go back to the cabinet and to leadership in the cabinet. We can have some internal conversations related to that.
So your preference would be through a state plan amendment, from what I heard you say, because of the flexibility there, or you really would like, would you like to say that today, based on what you know, your desire is a state plan amendment, but you reserve the right to go another route? Tell me again what you're thinking.
A state plan amendment is a little bit simpler. We pretty much tell CMS what we would like to do. They have 90 days to review that state plan amendment and get back with us. Sometimes, depending on the questions that they have to ask, it can take a little bit of a time, but once a state plan amendment is in place, it's easier to administer because we don't have to do the reporting, we don't have to renew it every 5 years, but it would be for treat without transport. If we wanted to explore triage and transport to a different location, that would be an 1115 waiver. So simply covering treatment without transport would be simpler through a state plan amendment.
Excellent. The $5 million budget impact.
And again, that's based on Indiana's state plan amendment that they have related to treat and not transport. And again, that $5 million would not be immediately up front. Over a period of time, we would anticipate those costs to continue to increase at some point till they leveled out.
So in my years of working with the MCO conversation and trying to understand that as it was implemented and has moved forward, it's long been spoken that the goal is for that capitated payment to that entity, the MCO, and that MCO providing coverage. The profit comes in the MCO reducing cost. And I would think that someone being treated and not transported would benefit the MCOs from a cost perspective. So where I'm headed is, wouldn't it benefit the MCOs if we could do this, and they should absorb that cost? Should they not? Or is the $5 million an implementation cost? Help me to understand.
The $5 million would just be when we pay the managed care organizations, we do pay them a capitated payment. We pay them a per member per month.
Sure.
Those rates have to be actuarially sound, and when we add services to their contract, naturally it's going to cost services to go up at first. So I think that would it save the managed care organizations? I'm not sure about that. We'd have to just monitor. My biggest concern is what's best for the member. The Medicaid program was created for the Medicaid member. We can't take care of our members if we don't take care of our providers. And I think that we all have the same common goal, and that's to create a better healthcare delivery system for the members that we serve.
Have you engaged the MCOs in a conversation about their willingness to participate in this or not?
We have had some initial conversations with the MCOs. We have asked if they do this in other states, for example. A few of them do. So they do have experience in other states.
Okay. Let them know that Senator Givens is quite interested in their answer.
We'll pass that along.
Any other members of the committee with questions? Great. Thank you very much.
Thank you.
Next on our agenda, we are excited to welcome to the table Shelley Hampton, and I believe we may have two county judge executives with you, Shelley. If you would bring them to the table as well, and as we always do, to the presenters at the table. Once you're seated, please introduce yourself for the record, and you're welcome to proceed with your presentation.
You just do it this way.
Okay, thank you. Good afternoon, Co-Chair Givens, Co-Chair Fleming. I'm Shelley Hampton, Director of Government Affairs with the Kentucky Association of Counties. Go ahead and introduce yourself.
I'm Casey Ellis, the Owen County Judge Executive. Also serve as a member of the CAECO Board of Directors. I'm the incoming president of the Kentucky County Judge Executive Association and the current legislative chair.
I'm Harry Clark. I'm the Round County Judge Executive, also the newest appointed member, I believe, to the K-Beams Board.
Well, I think I left my notes back there. JD, do I have paper back there? City-county collaboration. There you go. Always, always. Thank you.
Well done. You never miss a chance, do you?
Takes two to tango, for sure. Chairman, committee, thank you all for your commitment last session and to all stakeholders. Creating the task force that gives all of us a chance away from the hustle and bustle of a session to try to dig deeper into what is, without a question, a very complex matrix of the provision of and the need for this vital service and what solutions this whole group can move forward. We look forward to continue working with every stakeholder to ensure the highest level of service for all Kentuckians. Public safety is a top priority for every level of government, and counties are certainly on those front lines. Today, we will share a very brief overview of the numbers on EMS and the models currently in place to provide ambulance service in every county in Kentucky. As you can see on the slide, we have broken this down based on the best numbers that we could find, the data that is out there. There's about 6 different categories that we've been able to lump these services into based on county. And so that first section that you see, the county operated, where the county owns and operates the service out of the county general fund dollars. From recruitment and retention of employees and providing benefits to purchasing and maintaining equipment and keeping pace, of course, with all required training. The second one is taxing districts, SPGEs, special purpose governmental entities. The county has chosen to establish an SPGE to operate in the service and fund it through that property tax. The third you'll see on there is a joint city-county system where the fiscal court and the city commission or cities operate and fund that service. The next one is a regional. You heard from that last month. There is one regional from Barron and Metcalf that operate in the state, where 2 or more counties operate the unified service, whatever that unification consists of. The fifth one is where the county contracts with another entity to provide service. It includes those counties who work with either a private company, a hospital, another county, or a city to provide that service, and the county contributes tax dollars to pay for that service. The last one is that another entity completely and fully operates and funds, where a third party, again, hospital, a city, a county, operates and funds that service. So as you can see, there's really not a comprehensive answer when it comes to solutions that will have one solution that will fit all 120 counties. Some counties have attempted to contract with private entities in the past, but companies are not in the business of losing money, and everything associated with this service is very expensive. When a private company pulls out of a county, those citizens expect the fiscal court to find a solution to that. One of the overarching challenges assigned to this task force in the legislation and affecting all employers in Kentucky and beyond was to look at strategies for recruitment and retention, and that is certainly an across-the-board urgency for all of these services. To that point, you can see on that next slide, with the data we were able to find, the number of EMTs and paramedics working in EMS services versus other employment. We were not able to deduce where those other folks are employed, if they're still in that field or not, but they are licensed. And ideas discussed at September's meeting, like the treatment in place that was just discussed, or the treat no transport, an overdue increase in the Medicaid reimbursement rate, and other waivers like the 911 being approved as a certified public expenditure, as the co-chair so eloquently described last month as being very interested in that topic, are certainly worth further scrutiny by all the stakeholders involved. So to that point, KECO has asked 2 of our county officials to join us at the table today and share some of their county perspective on EMS. So if I may, Mr. Chairman, I'll turn the microphone over and we'll start with Judge Ellis from Owen County.
Thank you, Shelley. Chairman Givens and Chairman Fleming and committee members, thank you. I really appreciate the opportunity to be here and give you just a really brief glimpse into the life of rural EMS and what it means in a rural community. As Jim Henderson would say, and I guess what's kind of become our unadopted motto, I guess, is once you've seen one county, you've seen one county. We're all very different, and not only from geographical and landscape, but from physical means. And as Shelley pointed out in that previous slide, there are counties like Owen County, which fund their EMS service solely from their general fund dollars, while there are a few that have contracts with private services, and then the remainder, of course, are funded through a taxing district that's sole purpose is to raise money or to collect taxes for funding EMS. So when we talk about EMS in a rural community, it's important to get this in your mind that there are 40 counties or 40 plus counties in the state that do not have a hospital. So there are 1/3 of our counties in this state that rely on EMS service as the only means of immediate medical attention. When you look at it from that perspective, it just gives you an overarching view of what we face in the rural communities. And so in Owen County, we're 30 minutes away from our closest hospital, and as you probably know, in some of the far-reaching rural areas in the state, those transport times can be even further than that, some double. So it's very important. Of course, you've heard from every group. We have all agreed that that in order to retain and recruit workers, we have to be able to provide a living wage. And in my county in particular, we're a rural county surrounded by urban areas. Like all counties, we constantly face an uphill battle recruiting attention workforce when competing with higher wages and benefits that are able to be provided by our urban counties and, in many cases, different healthcare sectors. Since I was elected in 2015, we've more than doubled our average salary wage for EMS. Unfortunately, the staffing shortages is more critical today than ever before, even with those increases. And those I'd venture to say that those increases are similar statewide. My point in saying this is just to shed light that we talk a lot about reimbursement rates and funding. Expanded revenues alone is not a one-size-fits-all solution. It's pretty evident. So, additional solutions, just to touch on briefly, things that we're doing. For the sake of time, I'll keep it very brief, but I'd love to have the opportunity to discuss further. Is in Owen County, we operate our own public transit system, and in some cases are able to defer potential ambulance transports and thereby relieving some stress on our EMS system while providing those needed transports at 70% less the cost in many cases. With Kentucky's robust public transit system, a few tweaks could allow for even more use and expansion of that service and help EMS services and provide the service to our constituents even greater. Additionally, we've heard that several counties across the state they're thinking about the way it used to be when we had localized training. We've talked a little bit about that. So the way that EMS or the way paramedic classes are designed today, it's more urbanized, and it is very cumbersome for folks in the rural community. In the last meeting, you heard from Barron and Metcalfe County EMS, who discussed their regional EMS approach, the solution that fits a particular set of counties. Since assuming my role as judge executive, I have had and will continue to have conversations with my neighbors about the possibility of regionalization. But the reality is that each county has an individual set of needs. So I just ask that when we discuss solutions, whether with what comes from this committee or in potential legislation, that we just look toward a variety of solutions to be additional tools to providing the best emergency service possible for our constituents, your constituents, and all Kentuckians.
Thank you, Judge. Judge Clark?
Thank you, Chairman Givens and the committee for allowing us to be here today. I wanted to just share with you, as I stated earlier, I was one of the newer appointed members of the K-Beams board. And I wanted to make sure that when I represent our problems to the K-Beams board, that I had a representation from other counties. I didn't want to just go into this with Harry Clark's opinion. So I reached out to the surrounding counties, and on the 6th of October, I hosted a meeting with 8 other counties in our area. Now, I'm fortunate in one way that I have a hospital located in our county, but it's also not necessarily a blessing, because when the shortage of paramedics and the shortage of ambulances, we end up doing a lot of transports for the surrounding counties. So for a population of 25,000 folks, we're doing about 5,000 runs a year. Roughly 1,000 of those are transports. But to get back on point, the 8 folks the 8 counties that was represented there were EMS directors, there were emergency services CEOs or chairmen of their boards. Also, we had the hospital CEO there with us. And, we had a 2-hour discussion. And I like to say that at the end of that 2 hours, I could come today and give you the magic bullet, but we didn't find it in our meeting at all. What we did come down to, as we all agreed on, was manpower. And how do you attract and how do you recruit? And I know you've heard this over and over. How do you get these folks to be able to do this? We get a lot of the transports, and it's not because the other counties are shredding off their duties. They don't have the people to do it. They don't have the number of ambulances to do it. Some of those counties has 1 ambulance up a day. So if they come to Round County to transport a person to a higher level of care, and those transports are getting farther and farther away. Used to, when you transported normally from Moorhead, you would transport to UK. Now we're going to Columbus, we're going to Cincinnati. So you're essentially tying up an ALS crew for a number of hours. But it comes down to manpower. So for us, and I think that's one thing we came away with from that meeting and those 8 counties there, and I think I can certainly speak for those 8 counties, that manpower is the issue, and how do we solve that? And all these other things, without a doubt, has got to be worked on. Part of it is the Medicare, the reimbursement, and all of those things. You can't continue to operate these ambulances at the cost that it's cost us to operate without some type of reimbursement. So I just wanted to share that with you, that I sit here and I represent the 8 counties in my area, and I think we're certainly united. We're willing to help, and we're willing to come up with ideas, or please bounce your ideas off of us, because we're actually in the trenches, have to do this. I get the calls at 2 a.m. from the hospital CEO saying, "Is there any way you can shake somebody loose to transport this person to a higher level of care?" And I have to make that call sometimes. So thank you, and I appreciate your time.
Mr. Chairman, be glad to take any questions anyone might have.
Thank you, and we're going to start with Representative Hart.
Thank you, Mr. Chairman. This is for all 3 of you, because especially you, Judge, that just had the meeting with your 8 surrounding counties. When you all met, everybody sitting here knows that the level of pay and money is definitely, the disparaging salaries is one of the issues with the manpower. But do you all, and the people you've talked to and been communicating with, do you think that if we opened up more ways to train and facilitate the education of paramedics to get them licensed, would that help in any way? Or did you all touch on that, or what's your thoughts on that?
We did. That was one of the topics, actually, was how to get certification. Back some time ago, you could get certified without, and it was before my time, but I don't think it was an accredited course that you had to go through a 2-year course. You could get certified with some probably a lot of on-the-job training or some other education in the field and be able to do that training. But without a doubt, if we could find a better way to pipeline, or more recruitment tools, or some other way to do that, absolutely, it would help us tremendously if we could work a way out to get more personnel. In the room, I'd say with the 8 counties, sir, some of them, it wasn't a matter of money. It was actually just a matter of finding the bodies. I mean, in Round County, I would hire paramedics tomorrow, if you know of any. We just don't have them, and it's not an issue of money. Maybe we're not paying us quite as much, but we're very comfortable on our wages. It's just we can't find them.
One quick follow up. Just when we're looking at certified licensed personnel, are you having harder? And I realize paramedics at the top of the scale because of their advanced training and what they perform in the field, but are you having as much trouble finding EMTs, BLS, and advanced EMTs as you are paramedics, or is it about the same? I'm just trying to get. I know in the areas where I live and where I've worked, what it is, but I'm trying to get a feel what it might be like in like Eastern Kentucky, where you're from. Are we having as much trouble getting EMTs, or is it mainly paramedics, or a combination of both?
Sir, in our area, it's both. It's just a matter of getting either one of them. It's kind of odd in our arrangement. We share paramedics and EMTs. We share those with probably 5 surrounding counties. So they'll work for us one 24-hour shift and take our time off, and then they'll go to another county and work. So is the same as the EMTs. So we're so critical when one of my EMTs gets sick, they're probably going to affect 3 county shifts around us. And that's just how difficult it is. So we, our folks are doing a terrific job trying to manage what we got, but it's just hard to manage when, people say you got to do more for less.
Yeah, and that's what I'm seeing when I'm talking to other areas too. I just wanted to, thanks.
Appreciate the question.
If I could, just to add, when we talk about the availability of training, the shortage has been building for many years, and it's evident from the numbers that you were supplied by K-Beams in their follow-up presentation. So that went as far back as 2018, where they only graduated or certified just over 100. About 20% of those were Lexington, so that only leaves about 80 folks, and then for 120 counties and hospitals that utilize them inside their 4 walls as well. So the lack of training provided by KCTACS when the program became accredited is what has built to this point.
Representative Meredith.
Judge Ellis, I know you've been pretty progressive in raising the salaries for your paramedics in your county specifically. What kind of effect has that had so far? And can you talk about what the actual level of pay that you all are paying to most of your paramedics right now in Owen County?
We are around the $20 range. We're around $70,000 a year for paramedic base pay on a 2448. Advanced EMTs are about $4 less than that. EMTs are about $4 less than that. So graduating scale.
Follow up. Have you, since you all have raised those salaries, have you all seen a significant amount of folks who have been willing to come into the system, or are you still just treading water at this point?
We're treading water because we're not the only ones raising salaries. We're a non-hazard system, generally funded, so we're competing with Northern Kentucky, Louisville, and Lexington. I'm speaking for Owen County, of course. Mostly hazard duty systems, fire department-based systems, with many more resources and financial offerings than we have. And to Judge Clark's point earlier, the employee base is regionalized, so we just really are just kind of sharing folks. The pool just keeps getting drier and drier and drier.
Thank you.
Thank you, Co-Chair Givens. I just want to, Judge, I want to get clarification. What you said. You said that I can't remember the exact phrase, but each county is unique. That's what I took away from it. And I know the K-Beams have made a presentation look at regional type of approach in terms of providing certification, hopefully awareness and so forth. But I got an impression that you think that might not work. I don't want to put words in your mouth, or you think it would work, and I just maybe I'm missing something.
I think there's opportunities there.
Okay.
Yes, when you look at Barron Metcalf, that's certified as, or classified, I should say, as a regional system. But really, it's just a cost share regional system. They don't share manpower or resources, so it's not a true regional system in the sense of what I've been discussing with my colleagues. For instance, I have one county that has a hospital. Judge Clark and I talked about this earlier. So in that county, their paramedics and EMTs run, when they work a 24-hour shift, they're on the road for 24 hours. In my county, they might work a 24-hour shift and we may not have a call. We had 3 days 2 weeks ago that we did not have a call. And then when it started, we had 4 within an hour and a half. So that's just the way emergencies go, right? So my sense and my conversation with my colleagues has been more from a resource sharing than anything, so that we could maybe filter our employees, since we're all sharing resources anyway. We're trading off medics and EMTs for the different days. So maybe we rotate those folks through, so they work a 24-hour shift and run for 24 hours, and they could come to a county where we don't do interfacility transports and have some downtime potentially. So when I talk to my colleagues about a regional system, I'm looking at it more from a holistic sharing.
Right. I appreciate
process.
that. Yeah, I appreciate that clarification.
But at the same time, we're all elected officials. We're all elected to provide service for our county.
Sure.
So it is a hard conversation to have.
Sure. So when you bring somebody on board, whatever the pay scale, where are they coming from? Are they local, or are they?
No. We have.
And how did you? I'm sorry to interrupt you. And
okay.
So where they came from? And so how did they become aware of what you're trying to accomplish, what you're doing, what your benefits are, and all that?
We actually 2 years ago started doing mailers, just like you do a campaign mailer. We did open records requests for K-beams for addresses of certified personnel within our region, and did mailers. So we've done mailers, we've done email blasts, social media campaigns, the same thing that our neighbors are doing.
Yeah. Well, Mr. Co-Chair, I just want to make another statement. I had a meeting yesterday with the CEO Council, and I also had a meeting with Kentucky Hospital Association yesterday. And obviously the workforce in healthcare is very short, and we all realize that. But we need to basically, and this, I'm speaking for myself and not anybody else, but we need to quit identifying the problem, because we know what the problem is. We got to start peeling back what the solution is. And part of the process that I'm seeing is awareness. And I think, and I appreciate you taking an aggressive approach of getting the message out, say, hey, we're hiring and so forth. But also we need to look at increasing awareness of what healthcare, how much there is a need in terms of getting workers into the healthcare, because you're exactly right. This has been coming on for several years, and all of a sudden the pandemic basically blew up in our face, and like, oh my gosh, we should have been more proactive, because there's a study back in 2013, 2014 or something like that went through and did some of this analysis. And this is more on the nursing side, but there's a good foundation in terms of trying to go after this. So my question to you all is, what opportunities to get more on a grassroots, granular level when it comes to exposing what you have to offer, what a great pathway to be a paramedic or EMT in the high school level, in terms of mentoring, in terms of internships, those sorts of things. Was that in, Judge Clark, did that enter your conversation at all in terms of getting more in a granular level? Because we can look at dual credits, we can look at all these other types of stipends and so forth. Yes, it's going to take money, and that's another issue. We can talk about money, but we understand that. So could you make any comments or thoughts about that?
Prior to COVID, sir, we actually sent our EMS director, went into the schools and worked with the school system. They had a very good relationship, and it was a recruiting, to make folks aware of what paramedics did, and it was a recruiting tool. Now, we haven't been back since COVID, But I don't think you'll find it any different than any other workforce we need. I think we're going to have to go back to the schools, and I think you make a very good point. I think we're going to have to go back to the schools with this as well and make them aware of how important it is to their community and the nation as a whole to do some of these things. And I think going back into the schools is a great idea, and maybe do it on a little more formal basis than our EMS director doing it.
And that is happening in our region. For instance, we have a regional ATC, so and they are actually trying to ramp up an EMT program, so that they would do that in high school. And then JCTCS is also in that region, and they've started a paramedic class, the first one there at their new campus in Carroll County. So we have started that grassroots effort in my region.
Okay. Well, thank you. One last comment. Sorry, I thought that was my last comment a second ago, and now one more comment. One thing I'd like for this committee to consider, as well as the Health and Family Services Committee, as we look at workforce, is the a P3, a public-private partnership that we can go through and do have some type of initiative to take private funds and maybe state funds. Once again, it's another issue in the budget, and do a match type of approach to look at those individuals that might be interested, and encourage them to look at paramedics, to look at EMTs, to look at this. Because I tell you what, if we don't have people there, you can't get them a hospital. You can't. Which we know right now. So it's something I'd like for y'all to think about and consider how we can look at this from a different perspective, from a P3 point of view, as well as looking at some type of level in terms of high school and getting more exposure with that. But thank you very much. I do appreciate y'all's, and I do appreciate y'all's working on 777 in the past. So thank y'all very much.
Thank you all.
Thank you for the presentation. I've got a couple questions myself. If you'll flip to your other slide that you have in your presentation, and I feel confident this is a slide that K-Beams may have brought to us in one of the early presentations as well, but it still struck me as I was looking at it and thinking about it. The blue box are those that are working for EMS service.
Correct.
The gray box are licensed but not working for EMS service.
Correct.
Start with the EMTs. We have more people that are licensed as EMTs that are not working for EMS services than we have that are working for EMS services. Where are they working?
That's a great question. We don't have that data available to us, and I think that's a challenge that something that could come out of this committee as well is all of us could do a better job maybe of reporting. EMSs are required to report that. Is that correct, Judge?
Correct.
So, Judge, you challenged us a moment ago with the campaign approach, because campaigns we like to target our voters. If you could target direct mail those 5,672 and email and text message, you could probably draw some candidates out of that group. I presume they're working somewhere with their licensure, or maybe not.
So the reason they have this number is because EMS agencies are licensed through K-Beams to provide service, and they have to keep a roster updated of folks that work under their license. And the only agency that is able to employ paramedics that does not have that same requirement is a hospital. So someone could easily say, with 1,435 of them working in hospitals, that's not a fair analogy. But at the same time, we don't know what that number is.
So I think one of the goals of this task force is obviously to bring people together for conversations. Legislatively, we can't fix everything, but we can sure bring a lot of people together. And so, Director Sloan, you're in the room. KHA is represented in the space. If there are some number in that paramedic space that are working in hospitals, we'd like to know. The more data we can collect, the more we can get our heads together and just know where people are working. That would be helpful. Judge Clark, I think that goes in some ways to your manpower question. Judge Ellis, I heard two specific things from your conversation: the public transit piece, and then also the localized training in the field, and the potential benefit of being able to do that. I think those will be some things we address in our final work product as things for us to consider trying to help with both the manpower question, because the manpower is the training in the field, localized training piece. That cost piece is interesting to me. I want to spend just a moment and probe there briefly. I'm naive, so being naive permits a person to ask questions that are not so very well educated. I'm creating space for myself to do that. A 911 call comes in. How do you know whether to send an ambulance or whether to send a public transit sort of system? Question.
So in Kentucky, an ambulance has to go.
Okay.
So
To a 911 call.
correct. So what we do is, a paramedic is charged with triaging a patient. So we counsel them on the medical necessity. Now, if they want to go to a hospital, we don't have any choice but to transport them to a hospital. But in many cases, just as we talked about the treat no transport, in many cases we can treat no transport or just evaluate them, triage them, and in many cases, I don't say many cases, I don't have the percentage, maybe 20, I think it's about 20% in Owen County that probably don't meet the medical necessity for an ambulance, and that we, make other arrangements for them. They just need to see a doctor. It's not emergency. It's not life-threatening.
Excellent. All right, I want to specifically thank you, Shelley, for bringing Judge Ellis and Judge Clark here. And judges, thank you for your leadership in your communities. I think I have one colleague. Representative Hart gets the final question.
Well, it's more of a comment going off of your question. One of the things that might be beneficial, and I'm not sure if K-Beams could do this or not. I know by working in the field, a lot of your certified EMTs, a lot of them are police officers, corrections officers, camp counselors. The EMT certification helps them provide a level of first aid and safety for their organization. So you're going to find some of the certified people working for other career paths. And I don't know if this is even possible, but I'm going to throw it out there since we're discussing things. If maybe when you do the recertification process, it would be, we couldn't get the information immediately, but maybe throw it out there and ask them if they're inactive, where they're currently employed, or whether they're retired. Because some of the people they're going to retire, but they'll maintain their licenses just in case if they ever want to get back into it. And I'm kind of one of them people. I've been out of it for a while, and I'm slowly getting back into it because of some of the need for the counties around me. But that might be an avenue to get that data. If people recertify when they send in their information, just ask them if you're inactive, where are you employed, or are you retired and out of it, or whatever.
So I'm going to play the role of connector now. Representative Hart, Director Sloan, both of you know each other. Post-meeting, let's have the two of you get together. If we need legislatively to do anything, I don't think we do. You probably have authority to ask these questions already, but get your heads together after the meeting. Great conversation. Thanks you all very much. Thanks for your leadership.
Thank you.
Next, we have challenges and proposed solutions. I love the proposed solutions piece for EMS and hospitals. Vice President Jim Musser, please join us at the table. As always, introduce yourself, and we're honored and excited to have you here, Jim. Thank you.
Take this PowerPoint down.
All set?
Yep. Green light's on. Good.
All right. Thank you. I am Jim Musser. I am the Senior Vice President for Government Relations and Policy with the Kentucky Hospital Association. And Co-Chairman Fleming, Co-Chairman Givens, thank you so much for inviting us to join you today. This has really been a great conversation that I've been witnessing. What I've got to say to you is probably going to be a little repetitive of some of the things that you've already heard. I'd really like to start out by saying how happy I am that we have already been meeting with K-Beams and how much we appreciate Mr. Sloan, the interim executive director at the Kentucky Board of EMS, because we've had some good conversations, and I'm anticipating that we're going to have further. As you've already heard from other panelists today, there is no silver bullet. This is a big issue. I think one of the things that the Hospital Association can bring to the table is that we have been looking at this issue from the nursing perspective, and I see a lot of similarities in our work that we've been doing with the Kentucky Board of Nursing that would apply with working with K-beams. It's going to take a real partnership because it is such a massive problem. It's an issue that requires conversations like we've been having. The KHA has been working with the Council on Post-Secondary Education. We've been working with KCTCS. We've been talking with some of the individual 4 years, and to Representative Fleming's point earlier, it's going to be very important to have support at the K-12 level too, so that young people see that there is an actual pathway for them in healthcare, whether that's nursing, whether that's paramedic, EMT training. All of those things kind of go together. Today, I'd really kind of like to focus on just a couple of things. First, behavioral health patients and the transportation of behavioral health patients. As you've heard through the course of these hearings, it's a thorny issue for all the provider types. We certainly agree about the shortage of EMTs and paramedics to staff the ambulance services, and so we'd like to recommend examining current laws and regulations that really create some unnecessary barriers to the increasing the number of these vital providers. One possible solution would be to establish some new training opportunities, unlike what you've heard from the other panelists. There should be opportunities working through hospitals, the community and technical schools, nursing schools, and even the high schools to make training more readily available for EMTs and paramedics. Current regulations impose rules on who can teach EMT and paramedic training, and sometimes that is a limiting barrier for who can get an education. And there are regulations such as 202 KAR 7:601 that impose limitations on the numbers of students per faculty by ratio. Some of that may be perfectly appropriate. There's a 15-to-1 ratio that may be perfectly appropriate for clinical training, but maybe isn't for classroom training. And those are the kinds of things that we think we ought to be examining. And we would love to work with our friends at K-beams and all the other stakeholders in looking at those types of things that might be keeping people from getting the education that we all want them to have. A review of the regulations really can be done without legislation. This is something that if the parties are willing to work on, we don't need legislation, but it does need to take place. You know, in the past, hospitals actually provided training programs and served as clinical sites for students, but the existing regulations do make that difficult. Alternative faculty for training should be considered, along with revisiting some of those historical methods that were used. Those instructors produced excellent EMTs and paramedics, and we ought to really take a look at some what I think are common sense solutions. For example, obstetric nurses used to be able to teach the OB module, but they really can't do that under the current regulations, and the hospitals would be interested in working with the other stakeholders to see if that's something that we could do again. Same thing, the ED nurses and respiratory therapists used to be able to teach intubation, and under the current regulations, that's not really something that's feasible. So it seems that there are some common sense changes that could be made, and we want to talk with the other stakeholders about how we might go about doing that. Again, we think these things can probably be done through regulation rather than through legislation. As part of KHA's Patient Transport Task Force, we examined the availability of classes and found no classes at all in large parts of the state, and even in the metropolitan area, there were very few of those. And you've heard from the other panelists about how that has caused problems in their local communities. That lack of opportunity is discouraging for young people who want to go into healthcare. We ought to be making sure that we're not discouraging young people from these vital careers. We need to be doing exactly the kinds of things that your judge executives were talking about doing, making sure that we're in the high schools, and the hospitals need to do this as well. We need to make sure that we have access to the high school students, and quite frankly, I would like for it to start at the middle school level, doing career days and making sure that they understand just how important these jobs are, how exciting the jobs are. I mean, you think about, you're saving people's lives, you're working as a team, you're really doing something that's making a difference for people. And I think that's very exciting. I can't imagine careers that would be much more rewarding than being the one that says, I saved somebody's life today. That is important stuff. And unfortunately, we're up against TikTok and YouTube where they're hearing from people saying, oh, nobody should go into healthcare. It's, it's horrible, it's boring, it's hard. Well, somebody needs to be there to say, yeah, of course there are times that it's boring, and you better believe it's hard, but anything worth doing is going to be hard. That's not a reason not to do it. In fact, let's give them that challenge. Let's challenge the young people to come into the professions. Changing the education component, addressing the shortage is going to really require some new partnerships, things that we haven't been doing in the past, and I think that involves KCTCS. I think it involves the 4-year schools. I think it involves EMT training in high schools, which we understand may be occurring in some counties. What we've discovered while we've been working with the nurses is that a number of states have been doing LPN training in high school. So certainly we ought to be able to do EMT training there as well. KHA is currently working with the Kentucky Board of Nursing and several other partners to identify ways to address these shortages. I think we can do the same thing on the side with K-beams and our folks who want to help us to put more paramedics in the field, quite frankly, more paramedics in the hospital. Turning to behavioral health, it's been such a thorny problem, and we would like to suggest a minor change to the way CON operates. We're not looking for rip it out by the roots or some major change, but we think that where behavioral health is involved, that there can be some tweaks that are made that will really benefit everybody involved. Patients would benefit if a hospital ambulance service established to transfer patients out of the facility under very defined circumstances could also move patients in emergency departments waiting for transfer to another facility. It would assist in meeting the behavioral health patients' need and, quite frankly, be an efficient use of resources. As all of you know, House Bill 777 allows the hospitals to establish ambulance transport to take a patient out of their facility without a CON. However, a hospital may not pick up a patient requiring admission, and that's a limiting factor, particularly for behavioral health patients. So if a behavioral health hospital has an ambulance service, they should be able to pick up a behavioral health patient waiting in an emergency department rather than just moving patients out of the behavioral health hospital. Many patients experiencing a mental health crisis who meet the criteria for inpatient admission are waiting very long periods of time in hospital emergency departments, sometimes for days, before they can be transported to a psychiatric hospital. And that's not right. We live in a state where we have laws on the books that say mental health is the same as physical health and should be treated the same way. And so I think we need to be looking at that parity and making sure that that parity is available for the psychiatric patient. A psychiatric hospital should also be allowed to pick up a patient needing admission from other hospitals without a CON, a separate CON. It would be a great benefit for timely service for the patient. And of course, the same benefit should be afforded to a hospital system, allowing its ambulances to transport between facilities as well. A new ambulance licensure category and/or standards for behavioral health transports could be developed with differing staffing standards that would be reimbursable by Medicaid. The existing regulations require EMTs and paramedics, even for behavioral health patients. The EMTs and paramedics do a great job. They are trained to deal with trauma, but it might make sense to have different education for those who are transporting behavioral health patients. Having regulations, having training specifically for behavioral health patients is something that we probably ought to be looking at. Those could be recognized through specific licensure standards and a specific licensure category. As you've already heard, the Medicaid rules governing coverage for ambulance services really need to be updated to reimburse for secure transport, whether the patient needs to be on a stretcher or not. Just because they're ambulatory doesn't mean that they're not facing a health crisis. Mental health patients are frequently ambulatory, but they're still in crisis. They're still an emergency, and it doesn't make sense that the ambulance service wouldn't be reimbursed for transporting them. They still need that safe, structured transport. They just don't need a stretcher. Non-emergency transport, and I would disagree just very slightly with the commissioner and what she was saying, particularly for behavioral health. Just because a behavioral health patient has been taken to a hospital doesn't mean that they can get the treatment there. Not every hospital has a behavioral health unit. It's sort of like saying, oh, there's no emergency with your appendicitis, even though the urgent care that we've taken you to can't operate on you. It's still an emergency. It's just of a different nature. And so we need to be cognizant of the differences that the behavioral health patients are facing. Under the current system, Medicaid funds, as you saw, were given to the Transportation Cabinet, and they contract then with various vendors. But that type of transportation is scheduled in advance for things like taking someone to a doctor's appointment. And that's not exactly what we're talking about here. We're talking about somebody who maybe is suicidal. And just because they've been dropped off at a hospital doesn't mean that they're going to get the kind of treatment that they need. So we'd ask that the task force evaluate the role that the system could play to alleviate transport problems, maybe so that rather than having things go all through the transportation department, maybe those things need to be under the Department of Medicaid Services and have that really treated a little differently than it is currently. This may not be the perfect solution, and we're certainly willing to continue to have that discussion, but it appears that there are really opportunities for improvement where this level of transport is involved. KHA is eager to work with the other stakeholders. We recognize that it's going to take some time, and quite frankly, we're going to need to continue working after the task force has expired. But we're looking forward to doing that, and as Co-Chairman Fleming was talking about, public-private partnership, I think, is the way that we're all going to end up needing to go before we actually solve the problem. It's going to take a lot of us holding hands and not always liking everything that we have to do in order to make sure that our patients have what they need. And with that, I'll do my very best to answer any questions you might have.
Jim, thank you for the presentation. You did bring solutions. Some are challenging, but all are well thought out, and I appreciate that very much. Dr. Douglas, you have the first question, sir.
Thank you, Mr. Chair. I guess my first question is, Mr. Musser, do we have a list of those recommendations? I didn't really see it in my information.
No, but I can certainly provide you a specific list.
Okay, I was going to ask if you could do that.
Happy
I think
to
that
do
was an
that.
excellent presentation.
Thank you.
One of the things I do want to say for those people in medicine, I've been in over 40 years and I haven't been bored. So I don't know where the bored part comes.
It's in the studying, Dr. Douglas.
Yeah.
We've in a previous life, I worked at the Mercatus Center at George Mason University, and students have a hard time. They're very used to doing this, and when they actually have to sit and study, it's that's boring for them.
Well, I just wanted to thank you, and if you'd get that information to us, I really appreciate that. Thank you, Mr.
Be
Chair.
delighted to. Thank you.
Jim, that would be good. If you could provide staff with bulleted notes or an outline of your presentation, I think they could get it to all of us. It would be appreciated. Any other members of the committee with questions for this presenter? If not, thank you very much. Appreciate your work. Committee members have anything else to come before us? Our next meeting date? November the 1st. November 1, 2 weeks. So we have a quick turnaround on this meeting. So all members be advised, November 1st is that next meeting date. And that will be a meeting at which we consider recommendations. So again, watch your email. Thank you, and meeting is adjourned.